Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, we have Dr. Jesus Gonzalez Lugo, Assistant Professor at Kansas University Medical Center in the Hematological Malignancy and Cellular Therapeutics arena. And we're going to talk about a drug that is expected to be on the market in the near future for myelodysplastic syndrome, Imetelstat, and Dr. Lugo will tell us how he intends to use it in his practice. So welcome, Jesus.
Thank you very much. I'm very happy to be here.
So before we get into the discussion on the drug, I just want you to help put in just very general, broad strokes how you segment your MDS, and we'll talk a little bit about what we have to offer these patients today, and then get into a deep dive on Imetelstat. So how do you segment your MDS?
Sure. So as we have it here, MDS, first we have to define what MDS is. So I would have to say that MDS has three main components. And MDS has ineffective hematopoiesis. MDS has cytopenias, which is low blood counts. And also it has a risk of progression to acute myeloid leukemia. Those are the three components of this. And low risk basically are patients that mainly have the cytopenias, which is the low blood counts, mainly anemia, which is the most common things that these patients have. And the high risk patients are the patients that have the more risk to develop acute myeloid leukemia. We can do this by several risk scores, but that is mainly the thing. And the low risk patients are the ones that many times we treat their symptoms, and the high-risk patients are the ones that we either transplant them because they have to go to an allo stem cell transplant, because that is the way that we can detain their progression to leukemia, or we have to give them other types of medications such as azacitidine or decitabine, so we can decrease their progression.
So obviously, we're going to hone down more today in this discussion to the low-risk MDS subset. So can you just give us just a broad general overview of how you approach your low-risk MDS today, and then we'll talk about the agent listed last, Imetelstat.
Of course. So we have several things for low-risk MDS, and in the current years, our armamentarium has increased. We have erythropoiesis-stimulating agents. We have luspatercept, which actually has come to the front line now, very recently. Luspatercept actually with the COMMANDS trial now, I would suggest that it should go to the front line before erythropoiesis-stimulating agents, because of the groundbreaking COMMANDS trial that works in about 60% of the patients compared to ESAs. We have lenalidomide, which works in patients that are 5q deleted, which is a subset of patients that have MDS. And like I mentioned, HMAs, which we give in high-risk patients, we can also give it in patients that are low-risk MDS, but we usually give it when we run out of options on patients, when other options when we run out of options, like I mentioned. And then we have this very fascinating new agent that is Imetelstat.
So can you talk to us about the IMerge study that has been the pivotal trial? And if I'm correct, this drug, we're in June this year, and may actually get approved if the FDA gives the green light in the next few weeks?
Correct. That is what we're expecting. So it's going to be very exciting if it happens. So the eMERGE trial was an international double-blind randomized phase 3 trial. And it included patients with lower risk MDS that were relapse refractory to erythropoiesis-stimulating agents, or that were not able to get erythropoiesis-stimulating agents because their EPO was more than 500. And also these patients were transfusion dependent. Of course, they didn't include patients that were deletion 5q, and they did not allow patients that had prior lenalidomide or HMAs. The other thing that it's very important to mention is that these patients were transfusion dependent, but if you can see, these patients required 4 units or more of transfusions. This is very heavy transfusions, 4 to 6 units. Many of these patients with other agents usually do not respond to anything. So that's something that I have to really clarify here. And these patients were randomized 2-to-1 to Imetelstat or placebo. The primary endpoint was 8-week transfusion independence, RBC transfusion independence, and secondary endpoints, were transfusion independence duration, 24-week RBC transfusion independence, and among others.
So it is an IV drug given every 4 weeks.
Correct. It is an IV drug, and it is given every 4 weeks and for about 2 hours.
And so what's the results? Like you're excited about this. Tell us what is exciting.
I think this is extremely exciting because, like I mentioned, these patients are heavily transfused patients that you would think that they would not respond because, like I said, having 4 or 6 units, and these patients had, some of them, the median was about 6 units at baseline that they were requiring. Many of these patients don't respond to anything. And if you can see here as well on the slide that we're showing, the hemoglobin rise of these patients on the Imetelstat was 3.6. If you see on the luspatercept, some patients responded only up to like 1.5. So we are seeing, I think, that a very potent drug. So that is exciting. The other thing is that it showed 40%, around 40% of the patients responded at 8 weeks versus 15% on placebo. So that is something, very good response.
So
And
good
of course,
response rate. That obviously is something that is better. It seems like you're saying these were heavily transfused patients, more so than perhaps the luspatercept in the ESA trials. Is that fair to assume?
yes.
And how durable were the responses?
Well, the responses, as you can see here, the responses go down with time. But some patients were able to respond up to a year.
That's not bad.
That is not bad.
And then obviously you mentioned there are various risk stratification schemas for MDS. And so how does this do for the various risk groups within the overall low risk category?
Correct. I think I misspoke. I wanted to say some patients responded more than a year, nor up to a year. So yes, so patients that were IPSS low versus patients that were IPSS intermediate, the patients that received Imetelstat, they still responded versus the patients that received placebo. Most of the patients that received placebo that were intermediate did not respond compared to the patients that received Imetelstat, that everyone, irrespective if they were low or intermediate, they responded. The patients that were placebo, intermediate, no response, basically.
And I guess even using the more modern IPSS-R system, the results were favorable?
Correct. Also with the IPSS-R, patients with Imetelstat, when they were low, they responded. And again, patients that were IPSS-R intermediate, there is 0 response on the placebo arm.
So obviously a very marked improvement. And what about the cytogenetic risk categories divided by cytogenetic risk categories? Was there also a better chance of imetelstat doing the job?
Yeah, Imetelstat significantly increased the proportion of patients, irrespective of the cytogenetic risk category as well, compared to placebo.
And this may be something that not as many people are familiar with. What is IPSS-M?
So IPSSM is a new risk category that we have now. We used to have the IPSS, the IPSSR, and now the IPSSM is something that we have since 2022, is a new risk category that incorporates moleculars. So NGS is incorporated into the risk stratification, and it can give us a more detailed risk stratification. So some patients, because of that, because of the risk, because of the NGS or because of the molecular mutations, their stratification can change. So some of them maybe are changed to intermediate, some of that were intermediate go to high risk. So that is something that can happen. They can be recategorized.
So it
And
seems like this seemed to do the job, even if you use the IPSS-M system to
correct. So yeah,
sub-categorize.
so as you can see here in this in this slide, what it says is that some patients were recategorized as IPSS-M high risk because the study did not use the IPSS-M. It used and using the IPSS-M, some of these patients were recategorized as high risk, and they still saw a response with imetelstat.
So the other thing is that unlike ESAs and perhaps even luspatercept, which modifies, the cytokine milieu, perhaps this drug attacks the root biology of the disease and is perhaps disease modifying based on its effects on the mutational profile of the underlying disease. Is that what we take away?
You know, I am very glad that you're mentioning this exactly. So as you can see here, we're seeing that this has potential. This is modifying effect because you can see that it can decrease actually to 2 DNMT3A or ASXL1 allele frequencies. And they are correlated with longer transfusion independence. And this is very exciting, because it opens up the door at also leading to prolonging maybe overall survival, maybe decreasing leukemia reduction in these patients. It's something that we have never looked into in patients that are lower risk. And maybe we now may have the possibility to look into these things.
So, and again, that has probably got to do with how the drug works. As we said, the ESAs and the luspatercept group of drugs seem to modify the cytokine milieu. How does imetelstat work?
Yeah, so imetelstat has a very interesting mechanism of action. It's actually a first-in-class telomerase inhibitor. And telomeres are nucleotides that are at the ends of the chromosomes. What they do is that they prevent the chromosomes from breaking during proliferation, and MDS actually has increased telomerases, which maintains telomeres and prevents cell death. And basically what it does, and a telomerase inhibitor, it's selective at killing while allowing a normal residual hematopoiesis to reemerge. So selective at killing specifically these cells theoretically.
So, I think there's been some talk about the toxicity profile of this drug. So, what can you tell us about the side effects?
Yeah, so the side effects of this drug, there have been some important thrombocytopenias and neutropenias with this medication, grade 3 and grade 4, compared to placebo, about 60 in the 60%, that you don't see with luspatercept, that you don't see with ESAs. What I can say though is that they are manageable, usually seen during the first or second cycles, and they are reversible. But yes, it's something that we need to take into account. It's something that we will need to manage as well. And it's something that gets better with the dose reductions, with also delaying treatment. And it's something that we'll also have to maybe give prophylactic antibiotics or prophylactic antivirals, antifungals to this patient. So new strategies and new things that we will have to do. But regardless, I think, and the other interesting thing that I have to say though is that even though they had this important neutropenias and thrombocytopenias, it did not correlate with infections or bleeding.
So, as you seemingly mentioned, these seem to be sort of transient in the first cycle or two, and perhaps represent that you're getting rid of the malignant clone and the normal hematopoiesis is just taking some time to emerge. Is that possibly the explanation for this observation?
I think it could be, yes.
So then how do we put this together? So we're having an increasing number of options. Where do you see, if the drug is approved as expected in the near future, using this in your own practice?
I think right now, the way that we have to use it, or that I will use it, is for patients that have failed erythropoiesis stimulating agents, or patients that are not eligible to get them because their EPO is high or more than 500, that I know that they're not going to be able to respond, to have a meaningful response to ESAs. I think as well that it will give us the ability to do more clinical trials in the very near future. Because as I said, I think it's a very potent drug, as we can see. And we can take the example of luspatercept, that it was only approved for patients that were ring sideroblast SF3B1 as a second line after they failed ESAs as well. And now it was brought to the front line. So maybe something similar might happen to Imetelstat. And in the future as well, I don't know. I think that we have to be thinking about other things. Right now, luspatercept as well, there's a clinical trial, the Element trial, that we're looking to give it at patients that are not even transfusion dependent. So we're looking at many other things. So I think that the future in lower risk MDS, even though we don't have as many options as other diseases, I think that the future is still bright, and we're getting many other options. And I am very happy for these patients, because even though we call it low risk MDS, I think is sort of a misnomer, because these patients still have a lot of morbidity, because having a low hemoglobin gets you to having a very low quality of life.
So it seems like this drug does increment the hematocrit, but perhaps not the drug to use if you develop multi-lineage or cytopenias, in which case HMAs may be the preferred option. Is that how you look at it?
If you have, correct. I think that if you have multiple cytopenias, is something that you should not use. Of course, we need to take into account that it causes thrombocytopenia and neutropenia. So I would only give it to patients that have good platelets, that have and good neutrophil counts, good white cells, and I would only use it for anemia, correct. For patients that have other types of cytopenias, I would unfortunately still use an HMA. For patients that have thrombocytopenia, it might still be controversial, but for patients that have isolated thrombocytopenia and low blasts, we can use a TPO receptor agonist. Um, for Yeah, that is correct. And then the other thing I would mention is that it is not studied yet, but I think that we have to also look at other subsets of patients, maybe in patients that also have bone marrow fibrosis along with MDS. Maybe it might not be the best idea to give this agent either because they might have a lot of cytopenias as well, or cytopenias that might be brought up because they don't have that much reserve either because of the fibrosis. So
So it is being studied in myelofibrosis, and I think there's a pivotal trial that is seeking to show that it improves survival in patients with relapsed refractory myelofibrosis. So I guess they are venturing into areas other than MDS already.
they are correct. We
Well,
shall see.
Well, I appreciate your willingness to come and educate our audience about Imetelstat and the exciting development. Hopefully, we have this drug to give to patients in the very near future. And I hope I can count on you to come back and educate us about other exciting developments in this field.
Thank you very much. It was a pleasure, and thank you for having me.
Thank you.